We're here with Warren Dinges, who is with the Seattle Infectious Disease Clinic.
Yes.
And we're really pleased that you're able to take the time to present this program, because this is a whole new area of work, I think, over the last couple of years. PrEP has been growing, and we'll be talking about that. It's important. I think it's important that everyone today that has a risk of any account for HIV should be looking at this as a piece of the armamentarium. So let's begin the program and talk and address it.
Okay. PrEP is something I find very interesting, and a lot of new patients every week are entering my practice, and I'm prescribing PrEP for them to keep them healthy. So some people want to know, what is PrEP, first of all? So PrEP basically is pre-exposure prophylaxis for HIV prevention. This is meant for people who are proven to actually not have HIV, to keep them from getting infected. Right now in the US, that's a single medication that's been approved for it called Truvada. And it has two medicines in it, one called emtricitabine and the other one called tenofovir. And it's one pill daily taken to prevent HIV infection. And it's really intended for people at high risk of HIV infection. And it's based on some clinical trials that showed good protection for people who had good adherence to the medication. And the guidelines are actually from the US Public Health Service, and there's also some World Health Organization guidelines. And both of these organizations basically have said that men who have sex with men in the United States should virtually all be on PrEP if they are sexually active.
So when you say if they're sexually active, or could you say when? Because some people have this period of heavier sexual activity, and they would say, okay, maybe I better add this to, instead of just using condoms or having that in the mix, better be on that for the summer or
right.
Something.
It depends. I mean, it depends. People in monogamous relationships that are gay men, not really needed if you've proven you both are HIV negative. People who have only one sex partner, and it's a regular sex partner, and that's it, they're not at higher risk. So really, it's combined based on risk, and we'll go through some of those risks. So this is a question I had earlier yesterday. I said, what is the Google trends for PrEP? And so I simply entered the word HIV and PrEP for worldwide searches on Google. And as you can tell, starting from the far left in 2009 to the far right, February, there's been an enormous climb in the number of Google searches for HIV PrEP. So the question is, who really needs PrEP? People at high risk of HIV infection, as we have mentioned. This includes in the US, mostly men who have sex with men, but it also includes heterosexual men and women who are at high risk of HIV infection. It also includes injection drug users, and anyone who's sexually active with someone known to be HIV infected, as well as anyone who's sharing injection equipment with someone who's known to be HIV infected. And those are the populations really who PrEP is targeted for and who are at highest risk of HIV infection.
In the other program on antivirals, we talked a lot about adherence, and in this case, it's also important.
It is. Daily medication is important, and we'll talk about some of the impact of adherence on the success of PrEP later. So for men who have sex with men, we use the term MSM. Their risk for HIV infection basically, if they have an HIV positive sexual partner, either one or more of those, that's a definite risk. If they have inconsistent or no condom use within the prior 6 months, and we use a threshold of 1 or more receptive anal intercourse interaction or 5 or more insertive anal intercourse reactions as a marker of high risk. And then whether or not someone has recently, as in the last 6 months, been infected with a sexually transmitted infection, or STI, of gonorrhea, chlamydia, or syphilis. And then we also look at the number of sex partners, and really we stratify that according to people who have had more than 5 in the last 6 months and those who have had more than 10 in the last 6 months. And when I've been interacting with my patients, this is an enormously varied number. I have patients who have 10 sex partners per night. I have other patients who have had less than 5 in their entire life, and they're in their 40s or 50s. So we really have to adjust PrEP for those who are at highest risk. And then last, also, methamphetamine use, cocaine use, or poppers use, which are amyl nitrate, with or before sex is also a risk factor for higher HIV transmission.
Is that just the biochemical, or is it both the ability to reduce the a sense of inhibition.
I think it's mostly associated with the social inhibition, which then follows with non-condom use, higher risk behaviors that are also co-associated. And a lot of times, because of co-associations, you can't really pick just one of the two factors in terms of number of sex partners and methamphetamine use. That's been used in recreational settings for large numbers of people having sex, or at least certainly more than one-on-one sex. And then also having sex partners of unknown HIV status or anonymous sex, where you meet someone through social media sites, that is higher risk. And of course, commercial sex workers are at much higher risk. I have some patients who are in the erotic film industry, and I have them on PrEP because of their exposures, and also commercial sex workers of all sorts. The heterosexual risk for PrEP, basically we're looking at, again, if you have an HIV positive sexual partner. I have several women and men who have an HIV positive partner, and they just are on PrEP to prevent that transmission. Anyone who has inconsistent or no condom use within the prior 6 months and is heterosexual is considered at risk. And then also, again, recent bacterial sexually transmitted infections of gonorrhea, chlamydia, and syphilis within the last 6 months places you in a high-risk category.
It kind of tells a story there.
Right. And the high number of sexual partners within the last 6 months. I've been screening all of my patients who come in for PrEP visits in terms of the number of sex partners as well as the other sexually transmitted infections. And I'm finding a whole lot of asymptomatic sexually transmitted infections like gonorrhea or chlamydia in the throat that is completely asymptomatic. And they end up getting treated for it. And then lastly, again, sexual partners of unknown HIV status and also commercial sex work, even for heterosexuals, is also high risk.
Well, it's hard. You have gay men, and then you have MSM, men who have sex with men, who don't describe themselves as gay, but are nonetheless having these sexual experiences that are the same.
Or also bisexual men,
Right.
people who truly maintain that they have sex with both genders, and that's fine. And we don't really require that someone identify as gay to have the protection of PrEP. They simply, it's the behavior of having sexual interactions with men if you are a man, or a transgendered female having sex with a man is also a risk. And then the last real risk category is injection drug users. And likewise, as we discussed, sharing injection drug equipment with someone you know is HIV positive is a high risk event or behavior. And then any sharing of equipment at all places you at risk, whether you know the person has an HIV infection or not. And then lastly, for injection drug users, the sexual risk factors still apply. So men who have sex with men who inject drugs, they have the MSM behaviors, as well as heterosexuals who inject also have the same sexual risks that we look at.
Did you miss one there? Sure.
Oh, yes, thank you. So the question now is, who doesn't need PrEP? And I think that's missing from many of the guidelines. And I would say people at low or no risk of HIV infection. And those specifically are people who are proven to be HIV negative in a monogamous relationship, people who are not sexually active, because sex or injection drug use is what gets you at risk for HIV. And lastly, injection drug users who only ever use clean or sterile equipment and never share their equipment with other people are not at risk for HIV infection.
There are people that think that they also fit into this category because they have sex with serodiscordant, there's seroconcordant.
Correct. We call them serosorters.
But they really do believe that they aren't going to become infected. They believe that the person is telling them the truth, when in fact that may not be the case.
And particularly recently infected people can have extremely high viral loads. They may not even know they're infected.
This is when we talk about treatment as prevention, because it brings the community viral load way down.
Right.
When you have everyone on treatment, it's kind of herd immunity. But when you have people out there that don't know and they persist with not being tested, they don't know. So how can they tell you honestly that they are not infected?
There's almost no way to know for sure whether or not your sex partner is HIV infected or not. There are some home HIV kits where I've seen people who test them at home themselves and look at that as a guide. But even those test kits have a window where they're negative wrongly, where the viral load would be detectable, but the body hasn't made an antibody response yet. And those people can definitely, during that window period, transmit HIV very easily. So this Truvada PrEP, currently Truvada, as I mentioned, is the only drug approved by the FDA for PrEP in the United States. It has two medicines in it, emtricitabine and tenofovir, and it's made by a company called Gilead Sciences, and they distribute it worldwide. It's one pill taken by mouth daily, and it is available by prescription only in the United States. And prior to starting PrEP, you have to be tested for HIV, you have to be tested for hepatitis B, because the two medicines also treat hepatitis B. You need other STI testing for gonorrhea, chlamydia, and syphilis, just because the same behaviors that put you at risk for those diseases also put you at risk for HIV. And lastly, women need to be known that they're not pregnant. So pregnancy testing is required both initially and regularly throughout the testing. And lastly, also, injection drug users need good access to clean equipment so they can safely not share equipment. And all PrEP, Truvada PrEP, requires regular healthcare follow-up. This includes counseling, risk assessment, adherence assessment, and I see patients in the first month after they've been on PrEP, and then I see them quarterly thereafter. And they don't get more than 3 months worth of prescriptions, so that I make sure they come back for follow-up visits, because we don't want our patients infected with HIV on an inferior treatment for time so that they then become resistant to those two medicines. Yeah. And also, it's very important to realize that going on PrEP is not a lifelong decision. Many patients do start and stop PrEP based on their specific sexual behaviors. I have patients who go on PrEP when they're dating large numbers of people or more than one person, and then when they end up in a monogamous relationship, they will narrow to just one person, or narrow off PrEP to just one, and just continue off PrEP, and then later have another PrEP initiation visit if that relationship ends.
We're going to be, IFAR is going to be producing a program on the future of antivirals as PrEP. And obviously this is the only one that we have right now that's recognized, but there will be others down the line that will maybe be less troublesome, or they'll be injectable over, 3 or 4 times a year or something like that, yes, which will be much more exciting. But not all the companies are biting on that one. Some of them don't realize the benefit to that. Others are saying, no, just take the pills when you need them, instead of always being protected. Right. So, but we're doing that program because there is a future in it, and we believe that some of the docs are able to tease out what that future might look like.
And I think this is new for the companies too. They haven't seen PrEP of this scale before, and we're going to see how the rollout of PrEP into the basically mostly men who have sex with men community in the United States occurs, and what is the response? How much do insurance companies cover it? Are there difficulty at the follow-up? How do we remind patients to adhere? Because these are basically otherwise healthy people who don't take medicines, and now they have to go to the doctor every 3 months.
They have to learn how to be adherent.
They have to learn how to fill a prescription.
At a time when there's no drama as there was 30 years ago, even 20 years ago, when we were like, oh my God, if we don't take this, we're going to die, or all of my friends are dead because they didn't take
and follow-up, and there is a concern for drug resistance and people who become infected. And there's also potential side effects, and what you see here are the most common side effects that we're worried about. Nausea and abdominal pain was seen about 1% more than placebo in the clinical trials that we'll discuss. Headache was also seen, and then there's weight loss, which most patients don't seem to mind. So most people, or quite a few people, lose about 5 pounds when they start Truvada PrEP. Then there's also nephrotoxicity, which is a very rare but serious side effect. I've had 7 patients on Truvada who ended up on dialysis. Now, most of those were sick HIV-infected patients who were taking other medications, not young, healthy people just taking Truvada, but it's something that I bear in mind with every patient interaction that I have. And then there's a bone mineral density loss that's seen with all nucleoside analogs, but particularly worse with tenofovir, which may be alleviated whenever the TAF comes out, that it's a replacement for tenofovir that looks like it's not going to have as much of a bone mineral density problem. And they're also concerned about changes in risk behavior associated with PrEP. Will people quit using condoms? Will they increase their sex partners because they feel safer? And will there be, as you mentioned, less serosorting? Right now, there are people who serosort to HIV positive patients and only they have sex with those. There are people who serosort only to HIV negative patients.
Being negative.
Correct. And so they may less care about that because they know if everybody's on PrEP, everybody's safe, and so we don't need to worry about serosorting. And the question also then, we've seen some people PrEP sorting amongst gay men, where just simply because they will only have sex with people who they know are on PrEP is a way of ensuring that the person they're having sex with is actually negative. So, interesting. And there's also been some stigma associated with PrEP initially. I think much of that is falling away. There are still some community leaders who disagree with PrEP. There are some physicians who disagree with PrEP. I've had several patients referred to me from their primary care doctor because their primary care doctor did not want to prescribe PrEP and didn't think it was appropriate. So we'll talk a little bit more about that and some other interventions in medicine that are equally preventative that have been embraced just fine.
Now, you support PrEP. Are there doctors who really are, I mean, you say that there are doctors who don't believe in it. Are they well enough informed to really make that decision, do you believe, or do they just, out of hand, just think this is an expensive thing, this is a sexual activity, you can avoid the sexual activity, but they don't know the struggles that go on in a person's mind needing the sex?
Right. I mean, we saw the same thing with oral contraceptive rollouts. We saw the same concerns with like Viagra and erectile dysfunction medications. And sure, there's going to be people who just don't want to prescribe it. There's an education curve where we need to teach other providers about the importance of PrEP and how effective it is. And we'll talk about some of the specific numbers on percentages of effect. And it's actually extremely effective if taken. So the question is, how effective is PrEP? And I have it broken down here amongst the trials that have shown clinical efficacy. If you look at the top, MSM, there's an IPREC study, which was the first and was published in the New England Journal in 2010, 2,500 patients about, and they used Truvada, and they saw overall a 44% effect at preventing HIV transmission. There was also a US men's MSM safety trial. It wasn't really powered to have an efficacy assessment, but it was very well tolerated, and there were no HIV infections in the patients taking tenofovir. And then two other studies, which actually data will be presented at this CROI, one called the IPREC study, and the other one was sort of a rollout of PrEP in the United Kingdom. Both trials had their placebo arm stopped by their monitoring boards because of the effect they saw even at very early numbers, at early dates with relatively low numbers of patients enrolled. So they're actually stopping the placebo arm in those studies, and the basis for that will be presented at CROI this year. And not yet reported. From heterosexual studies, there was the one great study, it's called the Partners PrEP trial, and study of almost 5,000 men and women, and basically they saw 67 to 75% reduction in PrEP. And there's one other study, the TDF2, also quite effective at reducing heterosexual transmission of HIV. I listed 3 other studies. These studies were all stopped, or most of their arms were stopped due to poor adherence. Adherence in them was less than 30%, and I don't think they're really relevant for statistical comparison to the other studies that have seen very good results with good adherence. And the last study is the one, it's a Bangkok tenofovir study where they had about 2,500 injection drug users randomized to tenofovir alone or placebo, and they saw about a 50% reduction in HIV transmission. Now, if you look at efficacy based on adherence, you look at this has been narrowed just to the trials that were, in essence, good quality trials. And you see on the first column is the number of patients. The second column is the efficacy that you saw on the last slide. And then if you look at how we look at those numbers when they're adherent versus, and whether or not we can detect the drug in the patient's blood. For greater than 50% adherence in the IPREC study, you saw a 50% reduction in HIV transmission. Whenever you look at greater than 90% transmission, there was a 73% reduction. And in follow-up of the IPREC patients, so once they finished the IPREC study, they offered Truvada to the patients who were in the placebo arm. That's called basically an open label follow-up from their original study. In those patients, when you look at them combined with the original patients in the iPrEP trial, if they took more than 4 doses a week, there was a 96% reduction. And if they took 7 doses per week, there was a 99% reduction in HIV transmission. That is an enormous effect. Most of our best vaccines don't have that much efficacy. I mean, our good vaccines are 95 to 98%, and our bad ones are 60 to 70%. And our influenza vaccine this year was 22 or 23% effective. So clearly, PrEP is enormously effective. And with the heterosexual studies in the Partners PrEP trial, if you take the patients who are 100%, or I'm sorry, who were adherent based on reporting, or MEMS caps, I believe they used, they basically had a 100% reduction. And if you look at people who had a detectable drug in their blood, it was 86 to 90% effective. And for the TDF2, I will say that they saw an 85% reduction in the people they could detect the drug, but that was not statistically significant because they didn't look at enough patients in that study. And again, for the Bangkok tenofovir study, if you were adherent by report, it was 56%, and if you could detect the drug in the blood, it goes up to 74%. So in general, very good adherence shows very good effect at preventing HIV transmission.
It's like Mike Sag says, they ask him what are the drugs that are work, he says the ones they'll take.
Precisely.
That's very profound.
And as you mentioned, PrEP is going to change. And so at this CROI meeting, they're going to have the results of the iPrEP study. This is an intermittent or on-demand PrEP. And the idea with this was you would take 4 pills, 2 on the day before sex, and then 2 more daily after sex. And what we found, though, is probably those patients are taking quite a few pills, so more than the 4 to 7 pills a week. So they're more like the ongoing daily treatment. But we'll see if that's really the case. If there is a protective effect, even on people who only have sex maybe once every 2 weeks, is there still the treatment benefit in their on-demand use?
And I wonder, there's maybe no way to really tell how much different that'll be on the side effect issue.
Right.
Because it may not make much difference, but it will be some cost saving for those that are paying.
Yes, definitely, and we'll see. They saw similar studies with HIV with these structured treatment interruptions, trying to have people be treated and then off, and that didn't go so well on the HIV side, but it's a little different in prevention versus actual therapy. Additionally, as you mentioned, the injectables that are coming, there's one called cabotegravir that's an integrase inhibitor, and there's also a rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor, and they're already in studies looking at injectable PrEP to prevent HIV transmission. And so you would, in essence, go to your doctor's office every 2 or 3 months and get a shot to prevent HIV transmission. There's also likely going to be other dual nucleosides that are looked at. So Epsicom is one, and as I mentioned, when they're changing the medicine in Truvada to the TAF, we call it, you could sort of call it Truvada, which that will likely be used as another nucleoside option without the nephrotoxicity and with less bone concern. And then also post-exposure prophylaxis. This is for people who, say, had a single occupational or sexual exposure to HIV, perhaps through sexual assault, and they were given initially, they're broken down into either a medicine like Truvada or true antiretroviral therapy. They recently have updated those guidelines to just say, if you're at risk, we're going to use true antiretroviral therapy. That wasn't really based on solid data. It was really based on sort of thinking we're going to give you the best that we've got. A similar analogy could be made for PrEP. In essence, why not give people Stribild, Triumeq, Complera, or the new dolutegravir TAF that's going to be single pill once daily combination, and the only difference is the cost and the increased side effects for a higher level of protection. And then also we're going to see some mucosal antiviral medications, either vaginally or rectally, including gels and foams, as well as possible vaginal ring inserts of HIV medications like tenofovir. So PrEP is going to definitely change. It's on the enormous uptake, as the Google slide showed, and we'll see, I was told they're tracking this, Gilead Sciences, the company, and they're seeing it climb quite a bit.
We had a couple of organizations that are really looking seriously at anal sex that seems to happen, and it's presumed that it's always in male-male, but there's male-female for obvious reasons, for protection, for having children and so forth.
Right.
Is a natural way to do it. But there is this issue around, are the microbicides going to be as effective, or because they're not designed, the body changes, the body sections of the anus and the vagina are very different. And that's, for that reason, they need to make sure they're tested completely.
Yes. Vaginal tissue and rectal tissue are extremely different. And the probability of HIV transmission in each of those different tissues is different. And microbicides or antivirals will definitely interact differently in those two compartments. And the question really is, how do we best lower the risk of HIV transmission at each of the two sites? And it may not be a one-size-fits-all answer.
But that makes it complicated because there may be in this sexual event or series of sexual events over in the course of an evening, the use of both areas.
Right, definitely. And so I put this slide in as a thought of how other medicines been used to prevent disease. And this doesn't really seem that shocking to me when you actually look at it. So anti-parasitic drugs to prevent malaria. I have patients who travel to Africa. I put them on anti-malarials when they're there, and they come home, they go off them. I have patients, I give them antibiotics to prevent traveler's diarrhea, like rifaximin. Also, Pepto-Bismol is taken to prevent traveler's diarrhea. We give patients antivirals to prevent HIV transmission to discordant sex partners. So I have one patient with herpes infection, and she doesn't want to pass it on to her sex partner, so she takes an anti-herpes medicine. Likewise, we give metformin to patients who are at risk of developing diabetes before they actually have diabetes. We give anti-estrogens to women to help them prevent the development of breast cancer if they have a family risk that's high of breast cancer. We give statins to prevent heart disease. We give antihypertensives to prevent stroke. And certainly we give vaccines to prevent an enormous number of vaccine illnesses. So definitely prevention is something we do and we've been doing, and I spend a good portion of my practice working on preventative medication. So really the conclusions with PrEP are that Truvada PrEP right now is well tolerated, it's effective, and it is expensive. It's for persons who are at high risk of HIV infection based on those groups, either MSM, heterosexual people at high risk, or injection drug users. It's quite effective in clinical trials, 44 to 75% effective. And if you narrow that to people who take 4 to 7 pills per week, that goes up to 74 to 99% effective. In the developed world, the people at most risk are men who have sex with men and discordant heterosexual couples where one of the partners has HIV. And in the developing world, the risk is greatest with discordant heterosexual couples. And it will be interesting to see how we roll out PrEP in countries where there are very high rates of endemic HIV infection, where there can be 15 to 30% infection in some countries in Africa. And their healthcare systems just cannot support PrEP and the way we are now rolling it out in the US. There are many good copay assistance issues that are being addressed. In Washington State, we're the first state to have what's called PrEP-DAP, which is a drug assistance program where the state will provide PrEP to prevent HIV infection once you provide documentation of income and your physician visit and that you don't have HIV. The state will support that. It is a source of last resort. So first you're supposed to go to your drug company to file, and so then they're just covering copays mostly. Or if your drug company with a large deductible plan, still you have a large deductible in January, February of $2,000, $3,000 or more, that's when they will step in and provide assistance. And also the Gilead Sciences itself is also providing direct copay assistance. And that program has actually been working quite well, and it only takes a few clicks. It took me 3 minutes to register for the website when I went on recently. It's very quick to get their copay assistance card through Gilead. And what I can say is, as we discussed, PrEP will change. There'll be new nucleoside drugs that we use for it, and I think the injectables are where we're going to see some dramatic differences, where people are going in and getting a shot once every 2 or 3 months to prevent HIV transmission.
But that shouldn't stop people from actually doing something today.
Right.
And switching to that, yeah, surely.
Right.
Yeah.
Definitely.
Well, it sounds good. It sounds like you're supportive of it, and it sounds like the state is supportive. The state of Washington is supportive of it, and maybe there will be other states that are going to jump into the fray and say this makes sense.
And other cities are also jumping in. So Chicago, San Francisco,
some of those metropolitan centers that really are where it's most profound,
right,
prolific.
And it's where you can reduce transmission in a very direct and real way and look at community viral load.
Got it. Thank you very much. I really appreciate your doing both programs, the one on retrovirals and the one on PrEP. Thank you very much.
Thank you for the opportunity.